All right. Good afternoon, everybody. I'm going to get started. I know people will file in and get their food, but we got a great grand round speaker, so I don't want to take any of the time from his presentation. I'm Jürgen Onitzer. I chair the psychiatry department here, and it is a real pleasure for me today to introduce our grand round speaker. Before I do that, I'd like to say that today's Grand Rounds is sponsored by the Herbert Ripley Endowment Fund. Dr. Ripley was the first chair in the Department of Psychiatry. He started the department in 1949, right when our School of Medicine got established, and he was a chair for 20 years. He passed away in 1982, and friends and family and colleagues of Dr. Ripley established this endowment that allows us to bring back fabulous people like Dr. Atif Rahman, who's our Grand Round speaker for today. So let me introduce him after I shut my phone off. Sorry about that. Okay. So Atif is a professor of child psychiatry. He's in Liverpool. He actually lives in Manchester, but he works in Liverpool, England, and he's from Pakistan, and he still does a lot of work in Pakistan. And that has given him a unique opportunity to work in both rich countries and poor countries. And one of the things he'll talk to us about today is what is it that we in rich countries can learn from people who are doing very similar work in poor countries. Atif is one of these really smart, creative people who can connect the dots. So when he goes between cultures, when he goes between different settings, he makes himself little notes and he connects the dots later on in a very, very beautiful way. If you pushed me on who are the 2 or 3 psychiatrists that I've met in my career that I'm most inspired by, this guy is in that list because of this capacity. You know, he will go and look at different populations, different settings, and he's a practical thinker, and he connects the dots. And then he doesn't just think about it, he goes out and tries stuff. And a lot of the stuff that he does may or may not work out, but many of the things that he does do work out. And he'll share with us some work he's done in school-based mental health, some work he's done in communities that are really quite poor, where there aren't any mental health specialists, and where he's taught community health workers to do some really amazing work with mothers who are depressed, and then has the capacity as a researcher to follow these moms and their children and to really see what happens. And that's really amazing work. It's a really nice segue to what we had last week. Last week we had Dr. Myrna Weissman here, who's also spent a big portion of her career thinking about what happens to depressed mothers and their children. So I think it's a nice way to pick up from there. I think the work you will hear about, the other reason it inspires me is because he is really thinking not so much about what do we do when somebody is so sick that they're at a place like Harborview. He's thinking way upstream. You know, how do we make sure people are mentally well to start with? And I think when you start with moms and babies, that's the best you can do. I shared with you last week my story that 25 years ago I was asked by the Director General of the World Health Organization, who I was making a pitch for about mental health, and she said, we'll never do a lot in mental health, but if you only had $1 to spend on mental health, what would you do with it? And I said I would use it to help a depressed mom in a primary care setting. And she said, why is that? And I said, because this depressed mother is having a baby, and the baby is going to be in an environment with high cortisol levels and a lot of stress for 9 months, and when the baby is born, it'll be a baby that's a fussy baby. And that mom who's still depressed and anxious is going to try to care for that baby, and it's going to be really challenging, and those two are going to have a hard time, and they may not have really good attachment, and then when that baby becomes an adolescent, it's a very high-risk adolescent. It'll have depression and anxiety, and it might have an early pregnancy, and this is going to propagate itself. So if you only give me $1, that's where I would spend it. And this was 25 years ago. I didn't have good data behind it. I had read a really interesting article from the 1950s that John Bowlby wrote where he made that case, but it was all based on theory. And now we're 25 years later, and people like Atif have actually shown us that this is in fact exactly how it works. And not only that's how it works, that you can do something about it. So I'm going to stop here. I think you're in for a fabulous presentation of some really elegant, really inspirational work, and I thank you for coming and sharing that with us.
Thank you very much, Jürgen, for that introduction. And it's really a great honor and a pleasure to be here in this beautiful city. It's my first time in Seattle, and I didn't know it was so beautiful. The weather's been excellent, and I've really enjoyed my stay talking to colleagues who are doing a phenomenal amount of work in global health. And I wonder whether I got my title wrong. So bear with me. You may already know some of what I'm going to talk about. Nevertheless, let me start. Let me start by sharing with you a little bit of my double life. I live in England, but I spend a lot of time in Pakistan. Colleagues in Liverpool don't know where I am. That suits me. And they give me the freedom to do the work that I'm going to talk about. These are going to be my reflections on the work that my team have done in South Asia mostly, and the lessons about whether there is anything to be learned beyond South Asia. I leave that to you. So I will not be forcing any wisdom on you at all. So this is my front, the University of Liverpool, the first red brick university. You can see the building is of red bricks, and it came to be a statement for the United Kingdom educational system because it was one of the first universities outside of the exalted halls of Oxford and Cambridge, when education opened up its doors to the common person. And so it was a movement amongst tradesmen to be educated and compete with the Oxbridge elite. So it still carries that tradition and is a very democratic university. I'm also a consultant child psychiatrist, and this fascinating hospital that is a brand new £300 million worth of buildings is called the Alderhay Children's Hospital in the Park. If you're ever around in Liverpool, do come and visit the hospital. It's a very green hospital. You can hardly see it. It's integrated in the parks. And some very futuristic things there for children to immerse themselves in. But my other second life is often on a plane heading towards the South Asia. And I have been very fortunate to work with some very bright colleagues in Pakistan, India, and Bangladesh. And much of what I'm going to talk about is also their efforts. So first of all, let me just set the context, right? So this is a high-income country. You have a population that is quite scattered. You have to deal with the health needs of that population. The context in South Asia is different. The population density, to start with, is very different. So India, let me give you an example of India. India is 1/3 the size of US. So I guess Texas, Alaska, and maybe California, and that's India. All of the US population in these 3 states, the entire continent of Europe in these 3 states, and you've still got space for Brazil. So that's what the scale of the population is like. There's scarcity of trained human resource. So lots of people and very few trained people to help them. Overburdened health systems, obviously one of the repercussions of such a big population would be that systems are really creaking at the joints. Underfunding, stigma, literacy, those are the other big barriers to mental health provision. This photograph on the bottom is of the Kumbh Mela. It is a fair that is held annually in different sites along the Ganges in India. And I don't know how many million people attend it. Some say that about 5 million people come in to this fair religious activity. So it's humongous. how do you deal with this challenge? And so I'm going to talk about some of my work where we have tried to think about how mental health can be delivered in such a context. I'm going to talk in the context of perinatal depression, and I'll explain why I think, Jürgen has very eloquently made a case for mothers and babies being a very critical phase of life where interventions can make a huge deal of difference. But that is where I will, begin my journey. So the prevalence, for a long time, it was thought that depression, perinatal depression especially, was something that happened only in the West. So many studies, and this is one meta-analysis that we did a few years ago, show that the prevalence of depression amongst women in pregnancy as well as after childbirth is actually more than the Western Hemisphere. And there are many reasons for that, but I'll not go into those, just to say that the numbers are big. So if you break these statistics down into numbers, there are at least 20 million mothers every year who develop an episode of depression, and more than 90% of them live in low and middle income countries, and hardly any of them get any sort of treatment. Jürgen mentioned the impact of depression on the child, and now there's a plethora of evidence to show that maternal depression has extremely negative effects on infant growth, development, and a host of other socio-emotional outcomes. Again, I will not go into the details of this, just to suffice to say that developmental pediatricians and psychologists, the 4 authors there, none of them is a psychiatrist or a clinical psychologist, have called maternal depression a global threat to children's health, development, and behavior, and have actually approached it from a human rights angle, that to deny intervention to so many women at such an important phase of life is really verging on the criminal. Okay, so that's the context, that's the magnitude or scope of the problem. So where do you start? You obviously start with people who know what to do about it, but those people are almost negligible. So that's the ratio of mental health professionals, psychiatrists, psychologists, psychiatric nurses, and social workers in low-income countries. And you can see that the line is almost flat. So 1 million population, maybe 2 million population, and you have 1 psychiatrist looking after them. So that's not a good starting point when you have millions of depressed moms to look after. So when we started working on this, this conundrum, this problem, the WHO was very actively working on another less silent emergency, which is the HIV and AIDS epidemic. And one of their strategies to provide care to people affected by HIV was task shifting, or task sharing, as it is now more commonly known, which means that some of the tasks that specialists do are shifted to non-specialists. And so we looked at that. We tried to understand the basic principles operant there, and thought whether we asked ourselves the question whether treatment of depression through talking therapies could be delivered by non-specialists. And this study took place in Pakistan, supported by the Wellcome Trust. And so what was our approach to trying to understand this whole issue? Well, the first starting point was that we recognized strengths that communities may have, and the resources that the community may have. It's very important to go and do qualitative studies of how communities have been dealing with such problems. What do they call it? who is there to help, because oftentimes you will find some degree of intervention taking place in ways that may not be familiar to you, but nevertheless is intervention. Also go to the local experts, people who have been working in those settings for a long, long time, and treat them as the experts, not yourself. And then you will get glimpses of insights into how people manage such things with very limited resources. And then look at the evidence out there and look at what other people have done. So we looked at all of the sort of scope of psychological interventions that had ever been tried, and then tried to do a matching exercise of what the community did, what was available, how the two could be calibrated in a way that became not so foreign, not so vertical imposition, rather it could be integrated and weaved into what people already did. And to also have, right from the outset, the question of scale up in mind. You can work with a small community in a research project, but it was extremely important for us to think about scale up right from the outset, because we knew that the numbers were large. So we took cognitive behavior therapy as our starting point, but we looked at many manuals. We looked at how it's delivered in the West, in low-income settings, but then we dismantled the whole, the cognitive behavior therapy manuals, and we picked out the principles that were operant, the key active ingredients, and we then sort of translated and adapted them into a language that local community health workers with only 10 to 12 years of education could understand and relate to. Now, we found that the job wasn't as difficult as we thought it would be, because the women were working with other women. Remember, this is perinatal depression. And they understood the context of these women. And they had a very deep understanding of the lives of these women. And it was easy for us to intuitively explain the principles of how these women could be helped through the talking therapies. We gave it some structure, 16 sessions spread over 12 months at critical time points. And there were some extras thrown in. Although it's called cognitive behavior therapy-based intervention, but there was a heavy emphasis on family involvement, on teaching the health worker empathic skills of being available and giving that support to mothers, and most of all, making the immediate key family members aware. At no point did we call depression. To us, it didn't really matter, what we preferred to do was to focus on problems and how these problems could be solved when health workers, the family, everybody around the mother teamed up. So it was very much, let's work on helping the mother be the best mother so that the child, it's a shared, responsibility of the whole family and the community, could actually be the brightest and the healthiest in the whole village. So we used the child agenda as the Trojan horse to access families. Some of my mental health colleagues say that you should address the stigma of depression and take the bull by the horn. But why? I mean, why? If it doesn't make sense to the community that you're helping, trying to help. So the agenda of the mother-infant dyad worked very well. And it is also, I mean, that's how nature works too. I mean, the dyad is so intricately linked that it was hard to separate the two. Our intervention also had a lot of mother-infant interaction elements thrown in, a lot of helping mothers how to play with the baby thrown in. So it was, in effect, quite a child-focused as well as a mom-focused intervention. When community health workers, who were the healthcare delivery agents for primary care, were delivering it, that also helped take away the stigma a little bit. And homes as the venue and the engagement of the family also helped. Many of the women that we were working with were not literate and they couldn't read and write. So we developed some very locally influenced illustrations to help mothers get the concept of cognitive restructuring. So, which is a bit of a technical thing in those of you who are not from a mental health background, but that's one of the principles of CBT where you do some cognitive structuring. We did it through pictures. I'll just go back to this diagram of the threes. So we had three key strategies of CBT: guided discovery, which is a bit of cognitive restructuring, which basically means you try and shift the way a person thinks. You know, a person may be stuck in a rut, thinking the same pattern of thoughts that depress the mood, into thinking in alternative ways. And we use pictures to do that. The bigger chunk was the B of the CBT, behavior activation. So behavior activation was quite a key thing, and it's easy to learn for health workers. They were able to imbibe it, and problem solving when behavioral activation was not working due to extraneous factors. So there were three areas: the mother's own health, her engagement with the infant, and her relationship with significant others. And there were three steps. So it was all done in threes, easy to remember, formulaic, but allowing the mothers to, the health workers to really get the basic principles, and then just start working and learn on the job. That was quite important, experiential learning. And then we did a randomized control trial, about 1,000 mothers. It was a cluster randomized trial, so we had about 40 clusters, about 1,000 mothers. 500 got the intervention, 500 got some enhanced care through the primary care system. And what we found was that there was a very, very impressive reduction in the rates of depression in mothers who were being treated in this way by the community health workers compared to controls. But another interesting finding was that the diarrhea was reduced in the infants. There were more infants getting immunized. Contraception rate in mothers improved. We don't know what the mediating pathway was, but perhaps they were more empowered. They could, perhaps the family was more sympathetic, and perhaps they became aware that by investing in the child that was there, they could delay having another pregnancy. And the play frequency with the infant also improved. So these were the bonus effects of treating maternal depression, about which we were very pleased. So the intervention has now been taken up by the WHO. So if you want to see the entire manual, it's there downloadable for free on the WHO site. Just go to WHO and or Google Thinking Healthy, and you will be taken to the WHO site where the manual is available in English and Spanish. If you want to start to borrow some of the principles and use it in your own settings or in low-income settings, there's no restriction on it. The intervention is very much in line with the WHO's mental health intervention guide, which is quite a flagship sort of a WHO program that has all of the ingredients of what makes a good comprehensive mental health program, not just for women, but for all age groups and genders. It is perfectly in line with those principles. Right, so there was another issue then when we went to scale this up in Pakistan, and that issue was overburdened community health workers. And this is an actual photo of, and driving along the Grand Trunk Road, which is a historic ancient road linking Kabul with Calcutta, and our research office happens to be right on the Grand Trunk Road. You often see these trucks that are heavily loaded, and that's what happens. But the same thing happens to community health workers. They have all sorts of different programs that they have to look after. And sometimes the mental health component although it's so well integrated into their day-to-day work, can seem like an added burden. So we posed another research question that could peers, that's ordinary women from the community with no health experience, healthcare experience at all, could they be feasible people to deliver the program? And so my colleague Vikram Patel in India and myself, we were very fortunate to be funded through a U19 collaborative grant with through the NIMH to work on this very issue. We did some qualitative work with peers in two settings, Goa and Rawalpindi in Pakistan, and we found that ordinary women were very receptive to being trained to help other women. There were some differences between Goa and Rawalpindi, Goa being slightly more upwardly mobile, sort of happening town in a city in India. There were more expectations from, for being employed rather than being voluntary workers, whereas in Rawalpindi, which is a more rural community, women were much more willing to give their time. And so these are the papers. I won't go into the details, but the key message was that there is a huge untapped human resource. The same population density could be turned into an advantageous situation by training capable people from within those populations to help others at very modest cost. We are doing randomized controlled trials using this approach in the two settings. We should have the results by end of this year, and that should be something exciting because that could crack potentially the trained human resource barrier. Right, so I'll take another 10 to 15 minutes to talk about another project. And that project sort of illustrates the other challenge. So now you have human resource. Okay, you've identified a potential human resource. But how do you scale up training, supervision, the whole process of, think about the millions and millions of people. I mean, community health workers in Pakistan are about 250,000. If you want to train them and you want to continually supervise them and make sure that they deliver quality intervention, how do you do that? I'm going to move away from the perinatal example to another area which is very neglected. It is the Cinderella of a Cinderella specialty. This is developmental disorders in children. Nobody cares about a child who has intellectual disability or autism in a rural context, and it is the entire burden is left to parents, and they do their best, but are totally stressed out, and there's really nothing. Just imagine this is where I work in Pakistan, and this is a typical rural sort of setting, high up, in the mountains, maybe 150 miles away from the nearest center. This is the public transport. Imagine an autistic child being bundled into this bus, frightened, taken, half a day or a day's journey to the center where a doctor sees them for 15 minutes, and then they're back. Where do they live? And what is the doctor going to tell them? Often they're over-medicated. Really, the treatment gap is about 100%. So again, this is an example of an almost impossible situation where, what do you do? How can you do a scaled up intervention there? So again, we were fortunate with my team in Pakistan to be funded by the Grand Challenges Canada, have been very generous with their global mental health funding. And their vision was bold ideas, and the model, the framework that they sort of gave us was the integrated innovation model, which involved three overlapping circles of innovation. So if you want to scale up something, don't just think about your intervention or task shifting. Think about social innovations, technological innovations and business innovations and combine all three into an integrated package. So researchers, I mean, this model was useful. It forced me to think like, for the first time in my academic career, like a businessman. It forced me to think like an anthropologist. It forced me to work with people who worked in these areas and to understand how the computer viz could help us crack the scale-up problem, how the businessman with a kind heart could give us some business tips on how to finance such things. And I think it is the responsibility of academics to really learn from everyone else. That's one thing I really like about Seattle is how much, multidisciplinary working takes place, which is really wonderful. So, okay, back to this narrative of developmental disorders, rural Pakistan, 100% treatment gap. Not even the primary care physician knows what to do about it. And there are these 5 million kids. Yeah. So, social innovation, I can refer you to the papers that describe everything in detail. I'll be very, very brief because of time. But what we established was, again, using the same task sharing principles or task shifting principle, was to go into the community and talk to parents and ask them whether they were willing to be trained and to manage kids in a very scientific way, as scientific as we could get. Parental skills training, all the elements of how you manage kids with autism and intellectual disability, again simplified into an understandable package of interventions. Are you willing to be trained and then go and help other parents? And the answer was yes. People were willing to give time because they had a stake in it. They were managing their own kid, but at the same time, these are very close-knit communities, and having the skills and the knowledge to help other members of the neighborhood who had similar problems was definitely on the cards. And so we call this family networks. So we identified families that lived in the close vicinity. We identified one family member, volunteer, who could be trained by us and then who could go back and help train the other parents in parent skills training packages to help these kids. And we developed what we call family networks. This pilot project was done in a population of about 75,000. And so how do we go? Do we go door to door and identify kids? How do you identify families that have a kid with a developmental disorder, and how do you organize them into networks? And that's where some of the technological innovations, helped us. So we talked to, we were actually one of the partners of this project was a technological company in Pakistan who came up with the idea of an interactive voice response service, a free phone number that families could dial, and that had a screening tool embedded within it that helped identify families that might have a kid with a developmental disorder, and they could leave their address, and our system or the GPS embedded within the system could pick up where the call was coming from, or through the address, then give us the exact location of where these families were, and allowed us to develop a database of 80 families in this 60,000 population who called us. All we had to do was, through the community health workers, distribute a leaflet with a free phone number. They called us, and much of it was automated. So an automated database of families, and also an automated, they flagged up a family member who volunteered to be trained. So a champion, we call that a champion family volunteer, and families were identified using this technological tool that cost 1/1000th of a house-to-house survey or something like that. And the same system can be rolled out across the whole country without any extra cost. It's just the startup cost. Now, how do you train, so we were doing this at small scale. And so how do you train the parents? And if you're thinking about the whole country and thinking about the whole of South Asia, there are millions and millions of champion parents that you would need to train, and then they would go and train others. So it would be very hard to find trainers to do it. So there was another technological solution that we experimented with, and that was to adapt our intervention into a narrative form. So all of the principles of the intervention were turned into little stories or vignettes, stories of 3 families who were suffering, where a child is suffering from a developmental disorder. And their stories were narrated within this tablet. You press a button, the story starts from day 0. Well, it's like a soap opera, actually. Goes back in time, goes forward in time, has various characters. There's a doctor character who comes and gives some information. There's a nice little grandfather who is always frustrated and is always sort of trying to give his or her own wisdom. And then, how you deal with that situation. It's like a creative soap opera and very entertaining. But the parents who are watching it are able to imbibe all of the principles of parent skills training and management by walking through this narrative-based training tool. What it also has is an inbuilt supervision and monitoring tool. So the champion that we trained goes out into the community and trains 5 or 6 parents. Using the tablet is able to enter data about functioning, and I'll come to that, why functioning, on all of the kids that this champion is helping. And all the champions, when they come to our center for supervision, are able to upload that data into a central server. And like this, we are able to have data on baseline versus follow-up outcomes over periodically for the entire population that we are working with. The questionnaire was converted into a visual analog, again tablet-based. So the same tablet, you take the parent, you show them you press a button, and the question is read out in an illustrated form. The parent has to just use a slider scale to say how much the child is dysfunctional in that particular domain. And it was didn't involve all the training and standardization that is often required. Now, how do you replicate it? So, okay, we did this in about a 70,000 population with maybe 80 families. How do you replicate it across millions and millions of population? So we then also, as I said, you need to become almost an entrepreneur working with businesses to look at how they develop their business models. And we found that there were many social franchise there were organizations that could actually help you develop a social franchise model. How you could, a bit like McDonald's, where you have these restaurants that are franchised to anyone who's willing and able to run a business, but with very set quality control mechanisms and costed operations. So we were able to develop a model of social franchising and went to governments and charitable organizations to ask if they were willing to take up a 70,000 patch of population, be trained and quality assured by us, but they could run it. So we are in the process of actually working with the government who have money for people with developmental disorders to use that money conditional to the parents receiving the training. So it gave the government, which is very concerned about the health of people, but doesn't know what to do with it. And sometimes they just give cash to people, which is called conditional cash transfer, hoping that this cash would be spent on healthcare or improving the health of children normally. But making it conditional to receiving the training and then having meetings is actually, incentivizing the parents also. So this is just a rough example of what a business model might look like for scale up. So this is what the training video looks like, and I'll it's in Urdu, and it's just snippets of it, but this is what I meant by a typical family, a scene in rural Pakistan, and this is just how it runs. Just move it forward a bit. So it's in Urdu. Anyone understands Urdu? Yes, 2 people understand Urdu. So this is somebody telling how to play with the, sorry, I pressed the wrong button. Anyway, it gives you an idea of what the entire video is like that, and there are pause buttons and stop buttons, and giving instructions to the facilitator to have role plays, and have the parents work on activities so that they imbibe the interventions thoroughly. And it's very well structured so that it finishes in 5 to 7 days, and is feasible. Some other principles that I'll just briefly touch upon. We have been using the common elements approach, treatment approach, and for those of you who are not familiar with what this approach entails, these 2 references are really good. But what it is, you'd notice that we talk about developmental disorders, and that's autism and that's intellectual disability. 2 are very different. Conventionally, you have autism pathways and intellectual disability pathways. That's how specialists would conceptualize, these 2 different disorders. That's how we are trained to work with human beings. But I think that that's not a very useful model when you're talking of scale up, because the interventions that you do have so many common elements that it's almost artificial to have separate streams of people who are specializing in these. And therefore, we did away with the concept of diagnosis. So you only have problems, although we call it, the intervention for developmental disorders, but within the intervention itself, it's only problems. It's problem focused. So a kid who's violent, a kid who doesn't know how to dress himself or herself, and then what strategies can you try? A kid who's got, describing the autistic features, and then what you can try with that kid. Many of the communications, solid evidence-based early communication treatments have the same principles that you would use for early child development, cognitive stimulation of a normal kid. And so the principles are not very hard to really understand and apply them in a different way to a kid with autism or intellectual disability. So a lot of these artificial boundaries between disorders are iatrogenic. We create them. And the key outcomes are not symptoms, they're functioning. And functioning across multiple domains. So our aim is to get the kids to function better. The other advantages are evident that these can be delivered by a single worker, and they're less confusing and less costly rather than 3 or 4 vertical programs. And so this is just a summary of the research that we did on this. It's a pre-post. This is just a proof of concept study. So a pre-post study with all its weaknesses, but we found a significant improvement in all of the domains of functioning, except getting along with others. Perhaps that takes longer, and maybe that was just them. But so in most domains, and also participation in society, I guess, this was a 6-month follow-up. These are things that would take longer because these involve the community, these involve others who need to change, not just the child and the family. Socio-emotional difficulties in the child, the STQ was used, the strengths and difficulties questionnaire, significant changes there. Family empowerment, family felt more empowered, family felt that they were less stigmatized, and their ability to access other services was also improved. So we were very encouraged by these results, and so were Grand Challenges, who gave us some funding, and Autism Speaks, to now scale this up to 1 million population. We are in the process of doing that and having a lot of fun. uh, uh, because sometimes things just start going. I mean, the last time I was there, I met 40 champion mothers, and I was mobbed, and they all had their stories, and I mean, I normally I don't cry, but it almost brought tears to my eyes to listen to the stories that they had. It's almost it's like a movement. We've become like a constituency. I mean, a few more millions, and then we will have them mob the parliament. We can have them become an empowered group that can fight for the rights of these kids. And I guess that's part of the intervention, and stigma and awareness. And other things start to come in. The WHO has another wonderful initiative called Assistive Technologies. They've made a list of essential assistive technologies for children, for people with disabilities. Now they want to work with us to work with these families to provide assistive technologies at low cost. So we might be setting up small business models for parents to actually develop small workshops to develop these assistive technologies or market them, or. So when you start thinking like a businessman, interesting ideas and things start to happen. Another thing we are doing is setting up small schools, early child development centers for the moms. If a mom who has a kid with a developmental disorder gets the parent skills training, she is a wonderful, wonderful teacher for early child development of normal kids, because when you had the intense experience, the all other experiences are. Another model of self-sustainable financing is helping them set up schools, so they charge other community members only fee to help them learn about cognitive stimulation and early child development, and use that money to fund the local network. So another example of how one could think like a businessman. We're very excited about this really new initiative we have of a school mental health program. Again, another collaborative U19, which the NIMH is funding, to apply exactly the same principles. We are going to develop a technological tool that teachers can understand and use for school kids, and then use that to scale up school mental health in 4 countries of the Eastern Mediterranean region. And it's just started 1st of September. So the integrated innovation model, I think, is gaining some traction, and is hopefully going to be helping one of the pieces of the missing puzzle, in scale-up research. So I won't go into too much details. I know we are limited in time, but this is something that perhaps in a few years' time, we can talk about our successes and failures with this. Schools, teachers are a hard group to penetrate. They think they know it all, and they don't like anyone telling them that what they're doing is perhaps not. So it's a challenge. We have a challenge on our hands. What is our plan? Our plan is to have them invent it. So we have a whole group of teachers enthusiastically lined up, and they are going to tell us what to do. We are, of course, going to use a little bit of psychiatry to help plant some thoughts. Mental health, and people like Jürgen, really for many, many, many years, he's been a great role model for me, actually, although we are about the same age. His work with the WHO, he was talking about these ideas many, many years ago and trying to bring mental health out of the shadows. And I think because of the effort of people like him and all my other dear, dear friends in global mental health, it is coming out of the shadows. In April, I went to this great event that the World Bank and IMF organized, paid for it, and were actually very, very interested in innovations that could be scaled up. And so again, another role, another hat that academics have to have is that of a salesperson. So here I am trying to sell our perinatal depression to folks who hold the purse strings. And you need to develop these slick slogans. I thought this was a good one. Didn't catch on very well. Nobody's saying, I thought that maybe Starbucks could be interested in this, treating perinatal depression. So the depression intervention that I talked about, it costs less than $10 to treat a woman for 1 year. That's how cheap it is. And so you could, 2 cups of coffee, you can treat a woman for a whole year. And the impact on the infant and the child is amazing. And so having these sorts of policy briefs and really pushing the envelope with these funders is important. So which brings me to the conclusions. I have 5 bullet points. First, mental health is too important to be left in the hands of specialists. Those who are not mental health folks here in this room, you are the most important people here. If we want to scale up mental health, it's not us. We are useless. Non-specialists can deliver evidence-based interventions under supervision and can actually be better than specialists. It's not second-class, low-cost intervention. It's better quality care. Families and communities have a tremendous amount of resources and should be empowered. That's something that is hugely lacking in Liverpool, where, the National Health Service, it's wonderful and brilliant, but for mental health, maybe people think that we have all the solutions. I mean, what can I do about a kid who's just gone absolutely bonkers and is causing havoc? The family, we need to work very collaboratively with the family. And there are resources within the family, and we need to empower them, not disempower them, not make them passive recipients of services, but active partners in seeking care. And technology, finally, I mean, it's a wonderful equalizer. If a woman in rural Pakistan who's not seen the face of a classroom ever in her life can operate a tablet, efficiently, then that should be no barrier that education is a barrier to using technology for these purposes. And we need to think like entrepreneurs and find solutions to the funding issues. I'll just explain this picture. I mean, the English have a saying, carrying coals to Newcastle. And I hope that this hasn't been a case of that. Newcastle is famous was famous for coal. And if you take coal to Newcastle, obviously that's, what I mean to say is that you are doing some wonderful, wonderful work. I mean, I am so impressed by what's going on in Seattle that, I feel as though I have a lot to learn from actually your ideas of providing care to such a widespread population. Again, it's a resource issue, but of a different sort. And I think we can learn from this and take ideas to low-income settings, but also maybe some of these ideas are applicable to this setting. So I'll stop there and thank you very much for listening.
Thank you very much. You could bring us these kinds of calls any day. And if you ever get tired of Liverpool, we'd love to have you here. Be one of us. But short of that, I think you've given us enough good thoughts and inspiration that I think we've identified even over the last 2 days, a whole bunch of nice ways in which we could collaborate. So fabulous presentation. I don't want to get in the way. I think people will have questions for you. We have a couple minutes for questions. Anybody have any thoughts, questions? Nancy.
So what was the response of Starbucks to your pitch?
So the question is, what was the response of Starbucks to the picture, 2 cups of coffee for perinatal depression treatment? Well, we didn't actually pitch it to Starbucks. I was hoping that the message would get to them. But that was just a catchy slogan that we made, that, what's called a sticky message. I undertook a course on communication. And so I then implemented it for that workshop that we were going to. And so academics should really, I mean, your job is not finished when you've developed your intervention. I think maybe I need to go to Starbucks. That's job still in progress. But the thing is that it has gained. Policymakers don't have the patience to read our papers. So they need something on one side of A4 with sticky, catchy messages that grab their attention, and politicians like to think that, hey, this message I can use to get votes. And so that is how you develop a constituency that then is your ally, rather than dense scientific papers.
So a couple comments on that. First of all, you're probably about 10 miles away as you crow flies from the Starbucks global headquarters.
I'm drinking their coffee.
So that day, that opportunity might come. And one of the things that we all get trained to do, we all here are trained to be specialists, and then we are trained to be academics. Some of us are, and we're not trained to do any of that stuff that you just talked about, which is basically networking. And then when you get that audience, you have to have a message that's very different from what we all get rewarded for in academics. And I think that, what you said at the very end is a little provocative to many of the people in this group. You don't need a specialist to do this work. What are we all doing here, right? There's something very powerful in it, because if you can't have a non-specialist do it or explain it, you might never go when you get that audience. But if you can say, you need this, but I'm the only person in the world who can bring it to you. Starbucks knows very well that if there's only a handful of people who can do that, there's not ever going to be any effect in that, right? So I think it's absolutely true. We really do have to learn how to have other people do this work. The fear I always see, and sometimes it's really there and sometimes it's not. When you do a lecture like this, people say, what is this guy talking about? This is what I learned how to do. These people are going to learn how to eat by lunch. And I always have to say, I wish they could. You have no idea how much lunch there is, right?
That's absolutely, very well said. Very well said. I mean, yes.
I wonder if you've ever looked at the sort of demographics of some of your family volunteers or your champions. I'm just wondering, because certainly here in America, time is the most valuable things that anyone in the blue, white, upper class has. And so to volunteer do things is very difficult, especially if you have an autistic child. So I'm wondering if you've looked at that to see, would that be a barrier for implementing these sort of community volunteer activities in more developed countries?
Yes, so the question is are the barriers to volunteering your time in a more developed setting, where there are more pressures on time, is that a feasible option? You make a very valid point. We found differences even between Goa, which is a more urban type center, versus Rawalpindi, which is a more rural. And we found that in rural, agrarian, closely knit communities, especially where women don't have as much opportunities to do anything outside of the household, were more receptive and were more willing, where goodwill, community goodwill is the currency that people have. You do good to your neighbors, someday you're going to need them to do good to you. This is a much more applicable model, especially when you volunteer your time. Other places, there should be financial incentivization, and that has to be part of the package. You cannot expect entirely voluntary effort to deal with it. But having said that, there is something about volunteerism that has an intensity that is therapeutic if it is channeled properly. Community health workers at one time in Pakistan were semi-volunteers, and they worked tremendously well. Then they became empowered and went to the Supreme Court to get regular employee status of government officials. They got that. Now they're not as intense. I don't know. I mean, I have been confronted by the health minister of Rwanda, who stood up and said, this is exploitation. This is, you can't have volunteers doing something that the government is doing. And, I said, well, this is your worldview. We've done formative work. We've gone and asked people whether they would be willing to give their time, and they say, yes, we will be. Who am I then to say this is exploitative if the families themselves want to help, the communities themselves want to help each other? So I think I think the notion of some sort of a connected community is important. And so if there isn't one, we maybe need to create one. In high income countries around, I don't know, there are, mum clubs, or there are sort of communities around sort of religious, which is, tricky, but still could be done. Some community where you can then try and implement these, some semblance of a community. It could be a neighborhood, but it could be other communities, a sports club or a get well club or a mother and child club. In Liverpool, we are trying that through children's centers. The government funds children's centers where mums drop in. They drop in for any, low intensity health issue or just, and that environment gives us the opportunity to have these mums, work in networks. So things like that could be tried, but I very much take your point that it's not a one size fit all. So, yeah.
Let's do 2 more questions and then we'll let you go.
Right.
I was interested in the outcomes that you were tracking with the Mothers Project, where you track depression and other psychosocial indicators, and with the Developmental Disability Project, you were tracking functioning in different domains with the tablet. When you go into schools and you're doing your school mental health project, what sort of indicators will you use to show the effects of the school mental health intervention, and how will those be collected? Do you have that in mind?
So what sort of outcomes will we collect for our school mental health program? Well, part of it we leave to the teachers.
Things that matter to them.
So we have been sort of very open-ended in our proposal. And that's the whole idea of an implementation approach, is to work with the key stakeholders and to have them have their say in outcomes that can also be long-term outcomes rather than just the research outcomes. For our research project, for our RCT, we will have some outcomes that we will measure. For example, the strengths and difficulty questionnaire, again, is a useful one. To look at the socio-emotional health. We will look at other implementation type, how many kids were referred, how many kids thought and process, and qualitative type, how many kids thought that they got the help they needed, etc. So it will be a mishmash of outcomes, some for the RCT, but again, another key outcome will be functioning. We will use the WHO's disability assessment schedule, which is a functional impairment questionnaire for our key outcomes. And it's multiple domains. How do you get on with other people? How do you get on in your academic life, your family life? Those are the key things that we will be focusing on. Okay. So one last question. Yep. Thank you.
I was just wondering, especially in your rural example, when these champion mothers go out, they're helping other mothers during this very, very specific time period. What happens when something more serious or more long-term is identified, or they're not quite sure what it is, but they know it's something that's not quite within the norm of what they're doing? What kind of support do they have, and what kind of training would they have to recognize that that is beyond what they are participating in? What kind of support is there for the champion woman and for the depressed woman?
That's a great question. So the question is that what happens with mothers who are beyond the capacity of peers to help? So one of the things, and one of my slides has those 6 areas which are necessary for such peer or task shifting activities to take place. One of them was linkages with existing health systems. So these peers are not functioning in a vacuum, but are working very closely with the community health workers, who are also trained to recognize the more severe end of a disorder. Primary care physicians in Pakistan, whom the government is training in mental health interventional, medication, for example, they can dispense, who are in turn linked with tertiary care facilities. But that is something that I have come to Seattle to learn better, the collaborative care model, of how primary care needs to function in a well-oiled way so that they can pick up the cases that these community-based approaches aren't able to help. And so there is that, if you look at it as a pyramid, there is all of the ends of the pyramid that need equal attention. And I guess the collaborative care model where you strengthen the training of primary care physicians, nurses, community health workers to manage these problems in partnership with the community resources, then it really works. And there are things called the stepped care model, which also allow you to step up care when you recognize that it's beyond your capacity to help. I hope that helps. Thank you very much.
And that is a beautiful example of